So is Dr. Macario presenting today?
I believe so. They asked for the presentation
Right.
link last week. So
You then.
Thank you so much. So I'm going to present one case, and this is a 50-year-old female who had presented with symptoms of abdominal distension, bloating, fatigue, abdominopelvic pain, and moderate weight loss. I did not manage to get any other lab work that had been done. However, what we received at the histopathology lab, we received 3 specimens in one container. One was the left ovarian tumor, and this was a large, quite a large tumor that measured 17 centimeters, and it was intact, capsulated, with a smooth surface. On the cut surface, this was solid cystic, and the cystic component had a straw-colored fluid, while the solid component was tan in color. Then the other specimen within the container, this was now the uterus with both fallopian tubes and the right ovary. The right ovary was about 2 to 3 centimeters. And it showed on cut surface, it had some, it was not heterogeneous. It was not homogeneous. It was heterogeneous with almost like a small nodules within it. However, the uterus didn't show any remarkable pathology. Neither was the cervix. Then we also received in the same container an omentum, and the omentum had small nodules, tan in color. The largest was about 8 millimeters. So we went ahead and grossed the specimen. Now, after grossing the specimen, I took some slides from the left ovarian tumor, which was huge, about the 17 centimeters. And this is at low power. So at this low power, we are seeing these diffusely arranged small cells. At this power, we can appreciate a very cellular tumor, diffusely arranged. And we move slightly higher power. This was a diffuse pattern of small blood cuboidal cells. And these cells had very scanty cytoplasm. They were uniform in size. And the nuclear details, most of the nuclei had grooves within them. And so based on this, I formed an opinion that this is a granulosa cell tumor adult type, cell type. But now on the right ovary, the small ovary that was about 2 to 3 centimeters, I think the picture may not be very clear, but this is from the right ovary at low power. But you can still appreciate some glands here and here. When we go to slightly higher power, we are able to see we have some tumor here. These tumor nests, even here, and it's glandular forming. And also this side, this was also tumor. So slightly again at a slightly higher power. So we can see this gland here. You also have another one here. So still at a slightly higher power, I think we're able to appreciate that. But still, even within, outside these glands, we have these cells with some mitotic activity here. Even this one is a mitotic activity here. So this still slightly now a higher power. So we are able to see this tumor, nests actually of tumor even here. Mitotic activity were appreciable. I would put them at moderate. And these tumor cells are actually forming glandular pattern. So again, now we also had an omentum. The omentum actually showed a similar tumor as the one we have found on the smaller ovary. So at this power, we are able to appreciate we have some tumor here. Even here, all these areas have tumor. But when we move slightly higher power, this part of the omentum, we can see this tumor here. Even a gland here, glandular tumor there, and probably here. So another area, again on the omentum, this is the tumor, very pleomorphic cells, moderate cytoplasm. The nuclei have nucleoli, and you can appreciate the mitotic activity. So I went ahead and made a report based on this, and I'm going to present the report that I made. This is the report itself now, which is de-identified. The specimen was the left tumor, left ovarian tumor, then uterus with the right ovary and omentum. Procedure was TAH with omentectomy. For the specimen integrity, left ovarian mass, the capsule was intact. Right ovary, capsule intact. Fallopian tube serosa were intact, and the uterus was also intact. So for the gross specimen description, this is how we described it for specimen number 1, specimen number 2, and we described the other attached, the fallopian tubes, and of course one had a small paratubal cyst. So for the omentum, these were the measurements. I have said it had smaller nodules, largest about 8 millimeters. And we took sections which just label 1 to 5, which that was the left ovarian mass. 6 and 7 was the cervix. 8 to 9, endomyometrium. 10 to 11, the fallopian tube plus the ovary. Then section 12 was right fallopian tube, the ovary. Then 13 to 14, omentum. 15 to 18 is actually the nodular lesions. Initially, these had been grossed by a resident pathology, a student. So when I saw these kind of 2 different tumors, I went back to look at the gross specimen. and actually did a regrossing just to confirm, yes, it indeed came from the same specimen, but the diagnosis remained the same. So diagnosis for the left ovary, the histologic type gave it as adult granulosa cell tumor. Ovarian surface involvement was not there, had not involved the fallopian tubes. The uterine corpus again was negative for the tumor. Endometrium was important for me, but it didn't have any tumor. Parametrium negative. For the omentum, it was not involved by the granulosa cell tumor. So based on that, I gave it a pathologic stage PT1 and a FIGO stage 1A for that left ovarian tumor. Now for the right ovary, I gave it as histologic type of differentiated, moderately differentiated adenocarcinoma. Omentum was involved by the similar tumor. However, I did not see any lymphovascular invasion. So I gave a comment to the clinicians that this right ovarian abdominal tumor could be metastatic, probably from a different site. And at that point, I had recommended, because we have these CK20, CK7, just to run them and see how they would stain. However, I've not had the report for that. So my questions, why I have presented this case, is a question of whether these are patients having two primary different tumors, one in the ovary, one in one ovary, and the other one in the other, or these are patients having an adenocarcinoma somewhere else, like GIT, either metastasizing to one of the ovary and the omentum. So that's the dilemma. So back to you.
Okay, thank you for a beautiful case, and your pictures are gorgeous, by the way. So does anybody else want to comment on the case first? Just whatever your thoughts are. Zudi too, maybe?
I have actually similar to adult granulosa cell tumor for the one of the ovary, and adenocarcinoma probably metastatic for the second ovary, and the omentum, of course.
Okay. Anyone else? Okay, so I'm just going to jump in, and then maybe Lewis can throw in his thoughts. So I completely agree that, you know, the large ovarian tumor and the smaller ovarian tumor, that there seem to be two separate histologies going on. So very rarely granulosa cell tumor can have heterologous elements, typically mucinous differentiation, but to my knowledge, there isn't any malignant component of that sort reported. So I'm inclined to believe that the two tumors are metastatic. Yeah. And then there is also the this is a non-GYN, it's a metastatic carcinoma to the ovary and probably non-GYN. I would think it doesn't look colonic to me. So I would be thinking pancreaticobiliary. Pancreatic type tumor. So I don't really know where the primary is, but here we would do immunohistochemical stains to see if we can characterize the malignant tumor better. I think that's pretty much all that I have to say, Lewis.
Has a mixture of glandular solid morphologies. I was a little worried. I saw a bit of what I wondered if it was pigment or something. So I think I would even include melanoma on the differential, as it always can mimic those sorts of things in an odd way. Low stage serous carcinoma, I think, is in the possibility, but like you say, it's very localized to the omentum and the single ovary rather than more diffusely involved. So I think that has to be still a consideration, especially because it is certainly one of the more treatable high-grade tumors that you would encounter in this situation. The other question I wondered is, could this be a secondary phenomenon from a paraneoplastic hormonal effect from the granulosa cell tumor? And certainly there are, secondary endometrioid type tumors that are hormonally responsive to tumor or to hormone produced by a granulosa cell tumor that should be considered. But endometrioid carcinoma is usually a stage 1A. It doesn't metastasize early to the omentum, as this appears to have done. And it's usually much better differentiated if it's one of the type 1 hormonally responsive tumors. So this is less likely to be an endometrioid tumor, I think, than something else. And as far as the differential, Benita's right. The GI tract is a prime consideration, but more likely the solid GI tract rather than the tubular tract of colon or appendix or something of that sort.
Right.
So that's where the brown stains come into play. When you don't have a large panel of immunohistochemical stains that you can do, and the patient's finances are limited, I think at that stage, have to ask the question, what are the treatment possibilities for this patient? What are the capabilities in our institution? What kinds of chemotherapy do they have? And therefore, what can I do that would maybe influence or guide that treatment to the best degree? Certainly next generation sequencing is not the step to do if you don't have access to any of those targeted drugs and so forth. And so I think that depends a little bit on your institution compared to what we might approach with a bigger panel of antibodies and so forth to get to the diagnosis, because there's a lot of other clinical trials out there and drug options that people might have. So that's kind of where I would put it. I think, starting with CK7 and 20, that's very helpful. But most likely this is going to be a CK7 positive tumor, and you won't find a whole lot of other things that in your list of available options that it will stain for. So it becomes a CK7-oma.
Yeah. A couple of other things to think about is, did the patient have imaging studies. So, did she have a CT scan or an MR where is there mass basically in the pancreas or the stomach or somewhere else? That could also hint to a primary site. But I kind of agree that, she has advanced stage, high grade carcinoma. And if there's not a huge amount of differentiation between the chemotherapy she's going to get based on site or differentiation, then, perhaps, that just depends on your access and resources. Overall, I think that's as far as you can go with what we have. Any other comments?
Yeah, we at our facility, we'll be able to. I'm going to add that HMB45 for melanoma, so that then I'll also check with the clinicians whether they have done an imaging and all that, like CT scan abdomen. So these are things I'll be able to put to them. But I am glad that we are discussing this case because I showed it off to other pathologists. Yeah, they were of the same agreement that probably these are two different tumors.
Yeah.
Yes.
Yeah, I think if you could add a PAX8, that might guide it a little bit, because the GI regimens versus the GYN regimens are a little bit different. And if you could rule out serous carcinoma with a P53 or something, that would be obviously very helpful too.
Yeah, thank you. There's in Kenya, we are able to, even if we don't have some antibodies, we are able to refer such a case in a nearby hospital, private hospital, where the antibodies that we don't have, they are able to do that.
Yeah.
So I'll gladly do that.
When they do your stains, do they interpret them as well, or do they just refer the stains back to you for interpretation?
For the ones we do here, we do the interpretation. However, if we send a case, they do the interpretation, the other side.
Okay.
Yes.
Sometimes that's an issue where you have a stain that you don't see very much, making the right interpretation, especially with P53, which is a little bit challenging to interpret at times.
Yeah. So that's, thank you very much. I don't know, any other comments? Thoughts? So I have a couple of interesting cases. So if I could get sharing rights here.
Oh, you should be able to. Yeah, just let's see. But Zudita had a case too she wanted to bring up.
Oh, okay. Then Zudita, why don't you go first?
Sorry, can you share it? Because my network may not be stable. I already sent it.
Oh, okay.
Okay.
Dr.
Abby, do you have that?
I think you have
Yes.
to. Okay, good. You have to stop sharing for me to be able
give me
to share.
1 second and then I can share Zuditu's case.
Oh, okay. I'm gonna have to stop share. There we go. I misunderstood. Sorry.
Sorry. All right, 1 second. Okay, can everyone see this?
Yes.
All right, Zuditu, take it away.
Okay. Sorry, this is a case that we discussed it just today. I didn't prepare it for presentation purpose, just for consultation, because of the final diagnosis issue, especially for the staging purpose. This is a 72-year-old female patient presented with abdominal swelling. She's also a non-hypertensive and type 2 diabetes patient. Next slide, please. We received a total abdominal hysterectomy plus bilateral salpingio-oophorectomy, omentectomy, and appendectomy. The right ovary measures 27 by 24 by 18 centimeters with gray-white shiny smooth outer surface. Left ovary smaller, 4 by 1.5 by 1 centimeter. And omentectomy specimen, 45 by 15 by 1 centimeter with multiple mucus deposits. And fragment of appendix, 3 by 1.5 centimeter. The uterus and the bilateral fallopian tubes are normal in size. Also, they were unremarkable on cut section. Cut section through the right ovary, multilocular cystic filled with thick mucus material, and there was no solid area found. Through the left ovary, again, multilocular cystic filled with mucus material. Next slide, please. So this is from these images are from the larger right ovary. As you can see it here, there is a C-stole lined by this tall columnar mucinous epithelium with mild to moderate atypia. And because we don't have enough time, we took the pictures from more representative areas, and we couldn't find a clear-cut destructive invasion in the stroma. These are the pictures, some papillary-like structures lined. The lymphoid follicles are atrophied, the muscle proper is effaced, and the mucosa is lined by this tall columnar mucinous epithelium with areas of acellular mucin accumulation. And we couldn't find, we took a serial section and we couldn't find a destructive stromal invasion. I mean, both in a muscularis propria, also in the serosa, just acellular mucin only. Next slide. So these sections are taken from the omentum. As I have mentioned it earlier, on the growth, the omentum has multiple mucinous like cystic structure. So we took multiple sections, and what we found is this acellular mucin in the omentum with areas of this kind of epithelial structures floating inside the mucinous lake. Otherwise, aside from that, we couldn't find other more destructive invasion like the right ovary, the left ovary, and appendix as well. So our question is, how do we are going to finalize the diagnosis, the final diagnosis? How are we going to stage this patient? This is the issue. So back to you.
Okay, I think I can go first, but it's not going to be very detailed, in part because I don't do GI pathology, but Lewis also does GI pathology, so we'll wait to get his opinion. So from my perspective, the appendix is involved, and I think it's probably a primary, it's an appendiceal primary, so it would be I haven't seen anything in the images that would make me think of a Hammond. So it's a lamin, low-grade appendiceal mucinous neoplasm. But unfortunately, this is at high risk for progression because I think the omentum has mucinous epithelium also. And that's the extent of my GI knowledge. So Lewis, I'm going to transfer it to you.
Well, yeah, I mean, that's really about all we know. I mean, she certainly has cells in the peritoneal cavity mucin, and that is your distinguishing factor. If it's just mucin, then you oftentimes can get control and
Dr. Hassel, I think you might be muted now. I think we lost connection for a second and then
Yeah, okay.
there we go.
So HIPEC is the preferred method because conventional chemotherapy doesn't get to this. It's not responsive to that type of thing. You can't deliver it at a dose. And surgery is notoriously imperfect in terms of resecting all the available disease. So I agree that this is a appendiceal origin mucinous neoplasm. It's low grade. It's not a frank adenocarcinoma, high grade type of appearance, but it's got enough cells out there in the peritoneal mucin that it's going to be a challenge for her. And
So
this is unrelated to anything else you might have had in the ovary.
So my question is, this mucinous epithelium in the omentum, is that going to make it a low-grade mucinous adenocarcinoma, or because of the lack of this destructive invasion, are you going to still make a diagnosis of Lamin?
Yeah. So that's kind of it's kind of a terminology term. So it is a low-grade carcinoma, but it doesn't have an invasive capability other than through the mucin. So I think the terminology you use, I think you need to be very clear to make sure that the surgical care, because it's gone through a number of different progressions of terminology over time, from disseminated peritoneal adenomucinosis, which is kind of where this is, versus disseminated adenocarcinoma and so forth, and then the Lamin terminology, I think, is and Hammond are the more commonly used terms today. Even though we don't see an obvious site of invasion through the wall and the appendix, the concurrent morphology and involvement is enough to make this the appendiceal origin the primary site.
So the diagnosis will be Lamin, and it will be based on the presence of involvement of the right and left ovary and the omentum.
Yes.
Yeah.
Not adenocarcinoma.
No, not at least at our institution, we would not call it adenocarcinoma unless there was clear-cut something that looks
invasive
like
disease.
carcinoma.
Yeah. And that's to prevent overtreatment, because if they try to use, systemic chemotherapy with this, it's pointless.
Right.
It's just going to give you more morbidity.
Yeah, I mean, in the old days, they also used to do cytoreductive peritoniectomy, which is basically stripping the entire peritoneum, but I don't think anybody does that anymore for these things. So they just get HIPEC. They're not part of the reason for not calling, as Lewis said, adenocarcinoma in the metastatic site is that they don't respond to traditional chemotherapeutic mucinous carcinoma chemotherapy. So yeah, we would not call it carcinoma.
Very good case. Very good discussion.
Yeah.
Thank you.
Thank you.
And it is really important to make sure there's very clear communication, because even now with experienced people in our institution, sometimes you have to, back them up and make sure they understand this is not chemotherapy disease. This is HIPEC or surgical sort of thing.
Thank you.
Okay. So I can show a couple of cases if people for leiomyoma uteri, and I don't know about you guys, but we tend to do a CFIM protocol on the fallopian tubes, all fallopian tubes, where the distal end of the fallopian tube is cut off and then sectioned perpendicularly. And so this patient had this lesion in the fallopian tube. And I guess, I don't know, does anybody want to comment? Sorry. There we go. So just descriptively, it's a very small cluster of cells. I think it measured maybe a couple of millimeters, maybe 3 millimeters, less than 5 millimeters, somewhere around the 3 millimeter range. And it seems to be clusters of cells with slightly cleared out cytoplasm, low grade. But you can clearly see these nuclear grooves here. Clear grooves. And I don't know, any thoughts? By examination intraoperatively and by previous imaging, her ovaries were normal sized without any mass lesions.
Brainer nestes?
That's, yeah, I think that's one possibility. Any others?
Cord, stromal tumor,
Stromal tumor, what type of
granulosa,
granulosa?
granulosa. Yeah.
Yeah, so I think you pretty much covered basically what this might be. So it could be a Brenner cell rest. So Brenner, the distal portion of the fallopian tube where it connects to the peritoneum can undergo transitional metaplasia. And so you can get intrafallopian tube Brenner tumor, whether you'd call a 2 millimeter lesion Brenner tumor or not. I don't know. I probably wouldn't. I probably wouldn't even report it if it was truly just a Brenner-like area. But as I said, it had grooves, and I don't know who was speaking before who said granulosa cells. So I also thought that these were stromal cell differentiation. So we did, I believe this is I did that on purpose, which wasn't very smart of me to do. Here we go. Today. Nope. I don't know what we're doing. I'm sorry, I can't put the thumbprint we're not allowed to put up because of the, and I don't know why it's turned pink. But as you can see that this lesion is strongly positive for SF1. And so it is a stromal cell proliferation in the fallopian tube. And these are reported. So they're stromal cell rests in the fallopian tube, and they behave in a benign way. The difficult thing in this patient is, most of the cases that have been described, it's less than 20 cases. They've all behaved in a benign fashion, but they had their ovaries removed, so you could be confident that the lesion in the fallopian tube was the entirety of the lesion. In this patient, we can't be sure that she doesn't have a small granulosa cell tumor in the ovary, but there are a couple of cases reported where just like my patient, the ovaries were retained, and they were followed for 4 or 5 years with no adverse outcome, acknowledging that granulosa cell tumors can recur with large gaps. So I don't know whether this is a granulosa cell tumor or just a granulosa cell rest. So I described it I signed it out as I think something like descriptively, I called it a granulosa cell rest, but in a note, I put in the differential diagnosis saying that, absent removal of the ovaries, one can't be 100% sure. So any comments, thoughts on that one while I pull up my second case that I was going to show? What did I do here? Let's see. Sorry, the images take a little bit of time to upload. Hmm. So this is a 56-year-old patient who presented with postmenopausal bleeding, and on imaging studies, I think she just had a transvaginal ultrasound, and she had a good sized polyp, which was removed, and which is what we have here. And I wonder if anybody would like to comment. I think we're seeing all three things in here. I'll do a quick description of what I see, and then maybe we'll do that. So I think they're clearly areas of polyp. So you can see the thick-walled blood vessel, the fibrotic sort of stroma, and dilated glands that are typical of benign polyp. But then in the polyp, there are these other areas of glandular proliferation, which is getting to be quite complex. And then the complexity becomes even more in some areas, such as this. Here you can see that, there's clearly the level of cytologic atypia in the glands is much higher than you would expect with multiple mitotic figures and prominent nucleoli. And then there is overt carcinoma, as we're seeing here, which is just solid sheets of tumor with prominent nuclei, nucleoli, quite a bit of mitotic activity. Some of them are showing, a little bit of metaplasia here. So you're seeing sort of pink, more ample cytoplasm here. So does anybody want to comment?
Serous carcinoma?
I'm sorry?
Could this be serous carcinoma?
Yeah, that was our question also, as to whether this might be. So clearly there's the endometrial polyp, which is at this point irrelevant. So there are two histologic patterns that we're seeing. One is this sort of tubular type pattern, which actually on low magnification makes me think of endometrioid neoplasia, which, like some of it may be atypical hyperplasia, and then some of it becoming more complex and carcinoma. But the degree of cytologic atypia is too high for it to be simply endometrioid carcinoma. The very large nuclei and nucleoli are very concerning for a high-grade neoplasm. And so, sorry, it takes a while to respond. And once you get so this is the P53 stain. And you can see that the stromal cells are positive. So there's nuclear positivity in the benign stromal cells for P53, but the glandular component, both the component that we thought was, showing much more cytologic atypia and the solid areas are showing a P53 null pattern, which is a mutated or aberrant P53 pattern. So this is a serous-like carcinoma that at least partially is simulating, it has been called the pseudoglandular variant or the endometrioid variant. And I have seen now a few cases where the carcinoma component is completely missing, and so you mistake it for atypical hyperplasia. So when I have atypical hyperplasia, I really look very carefully at degree of atypia that the atypical hyperplasia has. And if the atypia is, to me, striking, then I will do a screening P53 stain on it to make sure that I'm not missing a pseudoglandular endometrioid type serous carcinoma. The other differential diagnosis I had before I did the P53 was whether this might be some variant of a dedifferentiated carcinoma, because if you don't take, depending on the cytologic atypia, and there's a lot of inter-observer variability about cytologic atypia, the solid areas theoretically could have been the dedifferentiated component, whereas the glandular areas could have been the low-grade component. Or even now we have high-grade dedifferentiated carcinoma, so that's the other possibility. But this typed as a serous carcinoma. We also do molecular NGS was done on it, and the only mutation, I mean, it has a bunch of other mutations, but it's copy number low and P53 mutant. So I just thought I would share it. The interesting thing to me is that all of these glands that, areas that to me look like, I mean, if I didn't have any of the other stuff, this looks like atypical hyperplasia.
Yeah.
So I just thought that this was, I've seen a few cases like this, and I've spoken to other people too, with the same sort of, so you do have to think about whether these cases, and so I think the other take-home message, although perhaps not usable in your circumstances, is that, I tend to do pretty much on every endometrial carcinoma a panel of P53, ER, and the two mismatch repair proteins PMS2 and MSH6, because that, the PROMIS algorithm helps subclassify these into molecular categories. So there is recognized now low-grade endometrioid carcinoma that is P53 mutated. We just don't have enough cases to know whether those, they seem to behave as high-grade carcinomas rather than low-grade carcinoma. So I just thought that this was a very interesting case.
So there's a question here, Vanita, just for my personal benefit. Having seen a number of these cases, would you do that panel on your atypical hyperplasia cases more routinely?
No, so
Here's the possibility you have a P53 mutation in that setting.
Right. So I pay a lot of attention to the degree of cytologic atypia. So I can send a paper out after the meeting. There's a paper, I think, from Martin Kobel's lab, basically saying that if you're careful about the cytologic atypia, you can select with good confidence for endometrial carcinoma cases that are likely to be P53 mutated. So I sort of extrapolate from that to the atypical hyperplasia category that, if the atypia seems striking, if you've got pretty prominent nucleoli and quite a bit of mitotic activity, I will do a P53 stain on it. And, we have started doing, if the patient was young, I would have done mismatch repair protein also because of the, but that would be in that scenario more for Lynch syndrome than for anything else. But if there's atypia, I'm going to, it's significant atypia, a lot of mitotic activity. I have found a handful of cases.
So the null P53 phenotype mutated status is an easy one for people to undercall. And in our laboratory, we very often will do P16 as a concomitant stain with that to sort of prevent us from calling a null type wild type, because the P16 will be brightly positive everywhere if you have that TP53 mutation.
Right. I typically also do a P16, if my P53 looks null, unless it's just very, very clear cut, I typically also do a P16 with it. It's very helpful if you have something that looks like a null P53, and if your P16 is coming back as patchy, then you really want to rethink about whether your P53 is, is not an overcall, because
Mutated.
that's where the
Yeah.
error happens. Yeah, you're absolutely right about that. Any other comments or thoughts?
Well, it looks like we'll be saving a few cases for next month.
Yeah. Yeah, and we're ending pretty much almost exactly on time. This has got to be a record somehow. Okay, so we will need people to volunteer to present cases for next time. So please volunteer and send an email